They're bad cats or they're bad. And wonder what I would choose for myself. Don't want to leave it up to my kids.
Ready? Okay. Okay, howdy. Hello, welcome. Before I introduce myself and really get started, I found this quote that I really liked, because palliative care hospices can be a touchy subject and difficult for a lot of people. This is a quote by Marcus Aurelius. The happiness of your life depends upon the quality of your thoughts. That was a neat way to kind of start it. So our talk is on palliative and hospice. My name is Kristin Sagebiel. I am a geriatric nurse practitioner. My specialty, a geriatric nurse practitioner, takes care of 55 and older in pretty much every aspect is for 55 and older. I graduated from UT Health Science Center in San Antonio 16 years ago with my master's. Before that, I'd been a nurse 9 years in hospital ICU telemetry. So I have 25 years as a nurse. And my passion is post-acute and long-term care, hospice, and palliative care. So I have a lot of experience with post-acute long-term care or in nursing homes. The facilities are sometimes referred to as nursing homes, nursing facilities. They're also called the post-acute long-term care facilities. And then assisted livings. I have done a lot with assisted livings and some independent livings centers also. I have 3 children. They're 11, 13, and 16. But again, my passion is palliative, hospice. I have always loved older people. I was very close to my grandparents growing up, and that was I had the opportunity to get a full scholarship for the geriatric nurse practitioner program, and I jumped on it because I've always loved and felt like I had a special connection with my grandparents and older people in general. And now I'm getting closer. I'm 50. I turned 50 this year, so I'm not too far from that. So our objectives are going to be to define the meaning of palliative care and hospice, identify the differences between palliative care and hospice, recognize when someone is appropriate for palliative care and hospice, name the symptoms treated with palliative care and hospice, and explain the financial requirements of each level of care. And this is going to be, I hope to get a lot of interaction with you guys. I want to hear what your experiences are. I'm very open for questions, and we could also talk about other areas, kind of like end of life type discussions, advanced directives, do not resuscitate, that type of stuff, if you're interested in learning a little bit more about that too. But the main focus will be hospice and palliative care. The palliative care definition is it's specialized medical care for people living with chronic and serious illnesses, such as cancer, chronic obstructive pulmonary disease, like emphysema, heart disease, like heart failure, coronary artery disease, ALS or amyotrophic lateral sclerosis, Parkinson's disease, dementia, and there's many, many more that goes along with palliative care, or that can fall into the palliative care. For palliative care focuses on symptom management such as nausea, pain, insomnia, anxiety, poor appetite, shortness of breath, managing those type of things. Usually a specialist like myself or another nurse practitioner, PA, or doctor can specialize in palliative care and usually make home visits in addition to their primary care provider or their specialist, like a cardiologist, nephrologist, any of the specialties out there, we work with them also. So palliative care incorporates the primary provider and the specialists also. To ensure the best outcome, and to improve the quality of life. Palliative care is about improving quality of life and trying to keep somebody out of the hospital. It's very individualized. It's a very individualized plan of care. So we find out more about the patient, more about the family, what each person's idea of comfort is. Somebody may not want to have any pain, where somebody else might tolerate a pain of 5, or a moderate pain and be okay with that. Or they may be okay with pain but hate nausea. We look at everything. We look at the whole picture, and that's where palliative and hospice both. We look at the whole picture. We get the plan. We listen to what the patients and the families' ideas for their life, their goals, their if they want aggressive treatment, we just take everything into account. It's a lot of questions. The first visit's like a very intense finding about the patient and what their wishes are and where the diagnosis is that they have and what's been tried and where they want to go from there. So it's very individualized plan of care. It's usually home visits. It's usually done in the home. Sometimes we will go to nursing facilities or assisted livings, but a lot of the visits are done in home. So that's another benefit, that we go to the home instead of having to go to another doctor's appointment. And we can keep people home longer. One of the goals is to keep patients out of the hospital and at home. So we might make a visit weekly, or it could be monthly, sometimes even longer, depending on how stable somebody is. If they need more symptom management because pain is an issue or nausea is an issue or one thing didn't work, then we might see them once a week or even more often. But the good thing is that it's usually in their homes. But we can take care of very sick patients in their homes sometimes. A lot of times these patients are very sick, but don't necessarily need to go to the hospital, because at the hospital, they've done everything that they can for them a lot of times in the hospital. So palliative care reduces trips to hospital and it reduces the cost of healthcare. So a palliative care visit may be, just say, $100 for a visit, whereas if you go to the hospital, it may be thousands of dollars for the hospital visit. It's paid by insurance. Medicare and Medicaid are your primary insurance coverage insurances, but other insurances offer palliative care also and will pay for it. And it's also a benefit if somebody is more a hospice appropriate, but not ready mentally, which I see happen quite a bit, then palliative is like a bridge, can be like, let's get you on palliative, manage your symptoms, and then when the time is right, transition to hospice. With palliative care, you can continue aggressive treatment. You can continue chemo, IV treatments, radiation, therapy, physical therapy, occupational therapy, speech therapy, that type of stuff. It's more, you can still have the aggressive treatment and still be palliative. Palliative doesn't mean end of life. Palliative means it's more about your quality of life and getting you as comfortable as possible. The hospice definition is, it's also a specialty, specialized care focusing on quality of life instead of quantity for people with a life expectancy of 6 months or less. So that's one of the big differences, is that hospice, a provider has to feel that a person has 6 months or less to live in order to qualify for hospice. Now, does anybody have any questions so far?
I just wish I had known all of this a few years ago.
Oh, do you want to share a story?
No, I'm just crying.
Oh, well, I would love to hear some y'all's stories at some point.
Well, maybe later.
Okay. Is anybody not very familiar with hospice and palliative care? What do I kind of want a little bit of feedback?
I guess I got a question.
Sure.
Since Barbara brought this up.
Yes.
I assume that your 9 years in the ICU led to decide to go into this field.
I actually knew because I actually started off as a nurse's aide and worked as a nurse's aide while I was getting my LVN. And I just knew that I would keep going, that I loved nursing and helping people and caring for people. So as soon as I got my LVN, I started working on my bachelor's, and I worked as an LVN so I could get the experience and get a little bit of money and along the way. And then I got my bachelor's as soon as possible. And then 3 years, worked as an RN for 3 years in the hospital. And I always pretty much knew that I was going to go back. I just wasn't sure exactly how that looked until 3 years later, when I'm like, I really want to be a nurse practitioner. And yeah, seeing patients in ICU is definitely a part of that. And there were sometimes like, I could diagnose and treat. I mean, and I have I'm very compassionate and want to help. And I thought the opportunity to be a geriatric nurse practitioner opened up for me. So that's, but yeah, I mean, all my experience as a nurse, and a lot of it was geriatrics. Most of my nursing was mostly geriatrics in the hospital in Kerrville. It was at Kerrville. So a lot of the patients were geriatric.
I've had experience with hospice care for both my mother and my father at the end of their lives, but no one ever referred us for palliative care. And I'm just wondering where that referral comes from. Who is likely to make a referral for that? Because I could see that helping a lot and could have helped a lot in my mother's transition of life. Who refers you to this?
Well, there's a huge need. There is a huge need for palliative care. It's still coming about, as in being more recognized and being utilized. It's just about to come to this area. I work for Hill Country Memorial, and I'm transitioning from hospice to supportive care, and it's going to open up in this area, and I'll be the supportive care nurse practitioner in this area. And so the referrals from specialists, we're going to let the specialists know, yes, we have this in the community. And so your providers will hopefully be aware that this is available. It's going to be the only palliative care program in this area as of right now. I've been in this area about 7 years, and there's talk of other palliative care programs coming about, but not that I've seen yet.
So it's quite possible they spent the end of their days in a small town called Glen Rose, Texas. It's quite possible that this wasn't available.
Very, very possible.
Okay.
Absolutely. Because it really wasn't even possible here until, I mean, it's still in the works, but it will be very soon.
Okay.
Yeah. And so getting the word out is one of the things that we'll be doing, so that people know that we're in this area, because it is a huge need, and it's very beneficial for many, many people and their families. David, did I answer your question? Did I answer it sufficiently?
I just thought you might have had some personal misgivings about feudal care on 100 persons.
Well, that's evolved. That has really kind of evolved as I've learned more. And what yes, I mean, sometimes it's too aggressive, but I've really, over the last few years, more than anything, I feel like that it's just so individualized that it all depends on what each person and their family's wishes are as to how aggressive we should be. So a 100-year-old could potentially live to be a few years older, potentially, and if they don't have any other cardiac disease, respiratory disease, late dementia, there's that potential that they can live longer. So some treatments may possibly be beneficial if it improves their quality of life. This is and so I will advocate for the patient, depending on what their wishes are. And somebody that doesn't want aggressive treatment, I don't want to force them to have aggressive treatment, whether they're 60 or.
Well, the question I asked was about
100.
your experience in ICU.
Yes,
So
yes.
they're already getting aggressive treatment.
They right.
in ICU.
Right. Okay. Yeah, that's a good question. I hadn't really thought about.
Well,
Yeah, but we
a lot
did.
of that goes to what you talked about is your advanced directives.
Yes.
A lot of people just need to get that out there and talk to their families and put it in writing, because otherwise.
Yes, yes, and that's where, yes, so I did see over the years in ICU too, where their advanced directives were not in place. And wow, people stay on life support for a really long time, or they get a feeding tube and they didn't want one. I mean, there's just so many different scenarios. So it really is, I cannot stress enough how important it is to get your everything in order. Even you might live another 50 years, but you get everything in order, because if you can't make that decision, somebody's got to make it for you. And it may not be the decision that you want, or it may be hard for your family to make those decisions because they don't know, or they may have conflict. They may have conflict like, well, mom, and we'll get to some of this in a little bit too, but well, mom isn't eating or drinking. I don't want to starve her or her to die of dehydration. Well, that's a normal part of the declining process. And if your loved one knows that you don't want to be kept alive with artificial means, then hopefully they wouldn't put a peg tube in you, because that's not a normal way of staying alive and doesn't improve your quality of life. So I kind of went off there, but okay. So the big difference with hospice and palliative care so far is that hospice has to have a diagnosis of 6 months or less to live. And that doesn't mean that you will die within that 6-month period if you have a hospice, if you're on a hospice. It just means there's that potential. I have seen many people stay on hospice for several years. I've seen people go on hospice and come off in a few months. I've seen people go on hospice and come off in a few years. The harder cases are the cases that they come on and they pass away within a week or even a few weeks, because then there's not time to be there for the family or the patient, and it can be hard. So that's another thing that we'll talk about too. Is, I mean, it's good to be, if somebody has a diagnosis of 6 months or less to live, the sooner the better to get on hospice is really the way to go, because there is such a huge support team there. Hospice Pearls, again, it's also individualized plan of care. We take everything into consideration, where they've been, what they want now, what they want in the future. Try to help them get things in order if possible. Hospice reduces hospitalizations. One of the big things with hospice is we want to be called, hospice should be called instead of 911. I say hospice should be called instead of 911 first, because we often can get somebody out of a crisis situation. Sorry for using we, but hospice can often get somebody out of a crisis situation when an EMS doesn't have to. There wouldn't be anything EMS would be able to do anyway, or more aggressive and something that the patient may not want. And then hospice, the goal is quality of life. And so however that looks to somebody, we try to improve quality of life. And with hospice, there's no amount of medication that's too much. There's no pain medication that's too much. There's no anxiety medication that's too much. It's whatever the patient's comfort level is. If they want their pain to be a 0, we try to get their pain to a 0. If that means that they are more sedated, drowsy, and sleep more, if that's what they want, then we're okay with that. It's very individualized, and it's very much based on just what that particular patient wants and what their family can handle. So sometimes we struggle with the patient wants no pain, but the family doesn't want the patient drowsy or sedated. So sometimes there is a big conflict there. And then we just have to talk through it. And sometimes it does take either the chaplain or the social worker or multiple talks to figure out something and come to an agreement. And that's it. So the interdisciplinary team works together with the patient and family. And again, that's there's a bereavement coordinator, there is a social worker, there's LVNs, RNs, certified nurses assistants. The certified nurses assistants provide bathing and a little bit of light housework. Sometimes, it kind of depends on what the need is. A lot of times we can keep patients in their house, even if they live by themselves, a lot longer than they would be able to stay in their house otherwise. And sometimes, a lot of times people want to, with their they want to stay in their house. They want to do whatever it takes to be in their house. And I've had patients that it was not the best situation for them to be at home, but that's what they wanted. So hospice really works with each patient and their families to try to meet the wishes of that person.
My husband stayed home from November through April. And the hospital bed was the main thing, and hospice coming. He was on hospice from November for a year, then they dropped him off. And by that time he was in a memory care. And he lived 3 more months after they dropped him off. So he did go back on hospice.
Did you feel like he received good hospice care?
I did.
Okay.
I did.
Okay, good.
And it was great help to me. He had to move to memory care because he weighed 200 pounds. I just couldn't do it anymore.
Yeah, absolutely.
So,
That sounds like a good choice for him.
yeah.
Yeah, and it does. It becomes, sometimes it's too hard on the spouse or the family.
He had chronic pain syndrome. So he thought he was in pain when maybe he wasn't, but he was loaded with whatever pain meds it took for him to believe he was comfortable with what we did.
Yeah, so I think I covered that. Stay at home. Yeah, just sometimes it does happen, like they do, your loved one, it was too hard for you at home. And I see that a lot. And then going to an assisted living or a long-term care facility isn't necessarily a bad thing. It can be a blessing. And we can talk more about that if somebody wants to. But that whole long-term care facility, assisted living is a lot of information too. But if you have specific questions or concerns about that, but it can, those facilities can be a blessing. And I've had a patient too that he did not want his wife to pass away at home because he still wanted to live there, and it was going to be hard if she passed away at home. So he wanted to take care of her, and he did to the very end, and he was so devoted, and it was so hard for him, but it was in his best interest in the long run for her to go to a facility, and she did pass away in a facility. He's able to stay in his home because she didn't pass there. So there's all kinds of situations, and
I hadn't even thought about that.
with that.
Was in the hospital.
Was it?
So hospice is good with handling the different family dynamics. We get some pretty interesting family dynamics as far as brothers and sisters or siblings arguing about what to do with mom and dad, or sisters or even moms and husband's mom, you know, like a 40-year-old patient that the mom was involved and the husband was involved, and there can be issues with that and what's the best way to care for the person. And that's where it takes, sometimes the chaplain comes in, sometimes the social worker comes in, sometimes it takes everybody. There are volunteers too for hospice. With COVID, that went away for a while, but it's starting to come back. And so hospice gets flowers that are donated and can be delivered. Sometimes volunteers will come sit with somebody if just to hold their hand even, or play a game, or the loved one needs to run an errand, and sometimes we can arrange for somebody to come sit with them for a while. So volunteers are another big part of hospice. The good thing about hospice is there's always a registered nurse and a doctor on call 24/7. And a lot of times the nurses do go out at night because of pain, nausea, falls. Somebody is declining, or to pronounce. Then RN goes out and pronounces at whatever time. Hospice pays for everything related to the hospice diagnosis, like medical equipment, like the bed, the hospital bed, bedside table. If they need a lift in the future, because they're not able to transfer, pull-ups or briefs, used to cover wipes, don't cover wipes anymore, but most things hospice does cover related to the hospice diagnosis, and including medications. Now, they do not cover the long-term care assisted living facility cost for the bed and food. Hospice doesn't pay for that, but pays for everything else. And again, it's through, hospice gets like a monthly amount for the patient, depending on the needs. And then that is distributed to pay for the meds, the equipment, the nurses aides, the chaplain, everybody involved. That's how hospice functions financially. Palliative care is more of like a each visit type thing, is paid for per visit. Does that make that clear? Any questions about that? Okay, sorry. Okay, I talked about the volunteers. Hospice just in general has more resources because it's a full team, interdisciplinary team. And again, I've already talked about the earlier someone is admitted to hospice, the better, because we are able to get in and really be there for the family, be there for the patient, get the patient comfortable. A lot of times we'll have somebody that's been in pain for weeks and they come on board and we can get their pain under control, and it's a blessing. And sometimes that person will get better because their pain is better controlled. There are patients will sometimes come on one day and die the same day. And we hope that doesn't happen, but it does. I mean, we hope it doesn't happen often, but it does for many different reasons. But the sooner they can get on, the better. The differences between palliative and hospice. Hospice requires a life expectancy diagnosis of 6 months or less, and palliative care does not have that requirement. So palliative care doesn't have that restriction, that time restriction. Hospice offers the full staff with the chaplain, the social worker, bereavement coordinator, the different levels of nursing. And palliative care will usually have a provider like the nurse practitioner, the PA, or a doctor, and then possibly a nurse, and sometimes one or two other people, but not so much of the whole team like that. There's not usually a chaplain or a social worker or bereavement. So hospice has more of the staff. Hospice doesn't provide aggressive treatment. Like if somebody still wants chemo or radiation, then they're not ready for hospice yet. at least whether it's physically or mentally, they may not be ready for hospice yet if they're going to seek aggressive treatment. But palliative care, again, allows you to have chemo or aggressive treatment or therapy. Somebody that goes to the hospital and, let me see an example, they may have advanced dementia. It may have been on hospice and fractured their hip. Well, if they're going to have the surgery, then they would come off hospice for the surgery. And then if they were going to go on therapy, then they could go on palliative care for therapy, like in a nursing facility, a skilled nursing facility. They could go on palliative care in a skilled nursing facility and have the therapy and then come back on hospice after the therapy. Some hospices will provide a little bit of therapy. Hill Country will actually, they're one of the few that will actually provide, Hill Country Memorial Hospice out of Fredericksburg, it's related to the Hill Country Memorial Hospital in Fredericksburg. They will provide an OT or a PT for a short period if needed, if it's going to benefit the patient, whether for pain or mobility, usually. Hospice pays for all hospice services related to the hospice diagnosis, and palliative doesn't. Palliative would just be your insurance that you would normally pay for, everything else. Palliative doesn't cover the hospital bed or the other medical supplies like hospice does. So does that make sense? Is that okay? And then palliative care doesn't, I mentioned that already, doesn't provide the bereavement services. So hospice will actually follow a patient's loved one after the patient passes, we'll follow them every so often, like 2 weeks after, and it depends on the need too. If the family is struggling and has struggled towards the end and then even after, we have hospices have a bereavement coordinator that will call the family and find out how they're doing. And sometimes the family member's not doing well. And the bereavement counselor or bereavement coordinator can talk with them and let them know what other resources are out there. Sometimes send a social worker or a chaplain out there. The hospice interdisciplinary team can make visits even to the family after the patient has passed to, have a meal with them, pray with them, just sit down and talk. So that's another benefit of hospice, is that they have that bereavement specialist that follows and can even follow a year or so after if needed. And sometimes it's necessary to follow somebody for longer than a year, because it doesn't, the grieving process doesn't stop after a year. And there is no set period on how long you grieve, and it can be a lifelong thing. That's another talk too. So when to seek palliative services? Somebody that's going to the hospital a lot, somebody that has COPD. Most common diagnosis I've seen where palliative care really can make a difference is heart failure, chronic obstructive pulmonary disease. Those two are probably the bigger ones that I see the most often, because there's that shortness of breath component, there's the anxiety component. They often go to the hospital because either they can't breathe or they're anxious, and a lot of times not being able to breathe can make you anxious also. Sometimes anxiety can make your breathing worse. So going to the hospital frequently, hospitals are starting to identify if this patient's coming in once a month, once every few months for COPD or chronic obstructive pulmonary disease exacerbation. They keep coming back for the same thing over and over. Or they may come in 1 month for heart failure and the next month for COPD, but they've come in quite a bit. Hopefully it would be a flag to them, to the hospitalist or the ER, and they would say, this person needs palliative care. Then palliative care is consulted and can make that initial visit and see what can we do to keep you from going to the hospital. And a lot of times it's something as simple as morphine, a low dose morphine for somebody that's having breathing problems routinely can really help. And I mean, like the lowest dose 3 times a day can really help with breathing. So things like that, somebody else might not think about, or the patient maybe wasn't open to it at first, or maybe the patient doesn't like going to the doctor, and would rather go to the hospital. So we can help with that too, because it's a provider coming out to the house to help instead of going to the hospital. Yeah, if somebody is tired of making frequent trips to their provider and they have chronic illness, they might want to seek palliative care. The desire to decrease medications. One of the things that I try to do is I go in to do a consult and I'm like, you're on a lot of medications. Do you like being on all these medications? If they say, oh, I don't mind, I try not to touch too many of the meds right away. But if they're like, oh no, I'm on too many medications, I start trying to cut back on their medications if possible. And sometimes people will do well being on less meds. Not always, but sometimes. So again, that goes back to that being the individualized care and what the wishes are of the patient, and each person and their family plays such a big role in both palliative care and hospice. But when we can decrease medications, that often is better. Any questions? Okay.
Sure. Just a point of confusion. When my mom she had vascular dementia and from an irregularity in her heart that was treated and fixed, but the damage was already done to her brain for lack of oxygen. And when she was declining, and this was never going to get better, right? The damage was already done to her brain. And it was definitely terminal. And they wanted to keep her on Synthroid for thyroid, but her behavior was very erratic. And they kept wanting to take her off Seroquel, which we used to kind of control her behavior. We didn't. She tried to do things like rip water fountains out of the hallway and pop people with towels, running up and down the hallway, locking people in rooms, things like that. Why would they want to put her and keep her on Synthroid when she's terminal anyway? And take her off Seroquel when she's crazy without.
I know. Yeah, sometimes it doesn't make sense. For the thyroid part of it, it can improve quality of life. But when somebody's not taking their pills regularly, they're not wanting to take their pills, they're not swallowing, then fine. It is end of life and that's okay. Just have to know that.
Well, I know there are complications from thyroid,
Right.
But she's already crazy and completely demented.
So a lot of it depends on comfort level of the provider, for one. You have guidelines that you go by in every specialty. And if you're not trained in end of life, then your goal is, okay, try to get better.
We don't do death well in the United States.
And that's right, we don't. So that's one of the reasons I'm passionate about it, because I want it to get better. And there's no real right or wrong for so much of it. And that's where I hope we can get past that barrier too, is everybody's pointing the finger a lot of times. But it's hard. I mean, that is a hard topic. And yes, if we stop the thyroid, there's going to be thyroid problems. But yeah, look, she's not taking her medication anyway. It's not going to be that effective because she doesn't have a steady, amount in her, and she's fighting crazy. Why? Try to give her this pill, and she might even try to bite when you're given the pill.
If you take her off for Seroquel, yeah.
Well, in nursing facilities, being on an antipsychotic which Seroquel is an antipsychotic, the facility can get deemed. They can get the state, they have the guidelines that the state looks at. And if they have very many people on an antipsychotic like Seroquel, they'll get deemed. They'll be like, oh, well, why do you have half of your patients on an antipsychotic? So there's so many different rules there, but facilities like to get the patients off antipsychotics when possible. However, hospice, we end up using Seroquel a whole lot. And Haldol is another one we use a lot because Haldol can help for nausea and it can help for that psychosis, that craziness. And we use Seroquel too, because again, it can definitely, absolutely a place for it. It just depends on the comfort level of the facility and the provider, and having a psychiatric advanced practice nurse or a psychiatrist that comes in and helps monitor those medications makes a difference because they can justify them being on the antipsychotic.
So when she was in Dallas and she was in assisted living, they had a psychiatrist monitoring and making recommendations on medication. They had no problems with being on Seroquel.
Yes.
When she moved to Glen Rose and they didn't have a psychiatrist on
That's a
staff.
part of it, absolutely.
But who all's on the staff is part of it? Who is there a psychiatrist? on
Well,
staff?
right. And what's their comfort zone with antipsychotics? It could have been that at one point they had everybody on antipsychotics because at one time it was sort of like that. And then that's why this, unless you meet these few criterias, these few points here, you should not have anybody on an antipsychotic. So then it went to the other extreme and then tried to take everybody off. But like you've experienced, it's not always good to, those patients that have the dementia like that, where they do have the psychosis, that's sometimes the only thing that helps. Okay, wait. Yeah, and the other, when to seek palliative service, and this is again, getting out there to the providers that palliative service is available, that you may in the future encounter somebody that says, so-and-so is appropriate for palliative. Let me point you in that direction. So hopefully providers, specialists will move a little bit more in that direction as it becomes more well-known. And I mentioned this earlier too, is palliative care, which also can be called supportive care. It sometimes is used interchangeably because palliative care, a lot of people don't want to hear palliative care, just like a lot of people don't want to hear hospice. It's like, death, and it is. I mean, it can be, but it's more about quality of life. And so palliative care, if somebody isn't quite there yet, yes, they may qualify. They may have even been told you have 6 months or less to live, but they're like, I'm not ready for that. I still want this, this, and this, or I don't want hospice. Palliative care may be more appropriate for them. And then when to seek hospice services, if a specialist provider says that you or your loved one has 6 months or less to live, then you more than likely would qualify. There's a lot of different diagnoses that we use. Cancer is a big one. ALS, or the amyotrophic lateral sclerosis. Sorry, I've got some of my notes I've got here. Some of the diagnosis that we use for hospice, the end-stage dementia. And it's not, it's end-stage dementia, not early dementia, not moderate, because somebody could live 10 years or even longer. Alzheimer's dementia is the most common type of dementia, and that is about a 10-year lifespan. But it's not always 10 years. Sometimes it is longer, and sometimes there's other dementias involved too. But dementia is a very common one that we do put somebody on hospice for, but it's usually when they can barely walk, they're not talking, not able to talk or communicate, and they need a lot more care, and they're not eating and they're losing weight. Then they would qualify with a dementia diagnosis. Heart disease is another one, liver disease, some pulmonary disease, renal disease, end-stage renal disease. If somebody decides they either don't want dialysis or they're tired of dialysis, they could be admitted to hospice for end-stage renal disease. Any questions about the diagnosis or how do you get on hospice? Okay. Yeah, so when aggressive care is no longer desired, if somebody's like, I'm tired of chemo, it's making me feel sick, I want to enjoy whatever time I have left. And the doctor says, yes, we feel like you have 6 months or less, then it would be appropriate for hospice. And when quality of life is more important than quantity, and still the other things, less than 6 months has to be there for hospice. But hospice does provide a higher level of care. So if you've got that less than 6 month diagnosis, life expectancy diagnosis, hospice can really be huge. And there's, most hospices are wonderful. I mean, they really, when you go into hospice, it's because you care and you want to make a difference and you want to help make people comfortable. So there are people that have had bad experiences with hospices, and like everything, you can have a bad nurse or a bad, just a bad scenario. But in general, hospices are loving, their staff is loving. It's not about the money. It's about what can we do for the person to improve their quality of life, and the person and their family to improve their quality of life for however long that is. And then the financial considerations, they're both covered by insurance. Hospice does tend to cover more. Again, the hospice gets like an umbrella, like a certain amount per patient, and then that's divided up amongst everything to pay for whatever services are necessary. And palliative care doesn't have that. That would be just billed for the provider to come out and look through the medications and see what can we do to get this person more comfortable.
If Medicare is your secondary,
Yeah, it still should work.
it's still okay?
Yes, absolutely. Because there is insurances provide some of that too. I think all insurances provide some hospice and palliative care. It might be a little bit different depending on if you had managed care versus not managed care, regular insurance. But yeah, it's usually covered. If somebody has insurance, then palliative hospice should be included in that. I'm not even sure what time it is, 2:50. I have other slides that, like symptom management, we talked about pain, shortness of breath. We have other symptoms that we treat, insomnia. A lot of times people have trouble sleeping. So we work with trying to get them to sleep better. Constipation can be a big issue, nausea and vomiting, anxiety, restlessness, depression, decreased appetite, weight loss. These are all things that we try to improve both for hospice and palliative care when possible. Sometimes we will put somebody on an appetite stimulant, because sometimes appetite stimulants also help with either sleep or depression too. One in particular that does. Any questions about treating symptoms? Okay.
If a patient doesn't want to eat, we found that they were force feeding my mother like you would a small child. Open your mouth, open your mouth, put it in, no mouth, close it slow. And she did not want to eat. Is that normal procedure? Is to kind of force feed them?
Not to force feed. Now, everybody has a little bit different view on it. There are some family members that are like, try to make my loved one eat as much as possible. You know, try to feed them. Don't let them say no. And I have to reassure, we cannot force them to eat. We cannot force them to drink. And weight loss and dehydration are a normal part of the decline because you don't have the same sensations. You don't have the same thirst and hunger sensations. Sometimes as you get older, but then different disease processes, different medications. So dehydration, we see dehydration all the time. And you don't really for palliative too, but hospice, we try not to do IV fluid because that's more of an aggressive treatment and your body's declining. The IV fluid is just going to help for a very short time. So we can't just keep somebody on IV fluid. That's not natural. You don't normally have an IV in your arm or a peg tube. You know, those are not natural things and your body can reject them and it increases risk of infection. And if somebody has trouble swallowing and the only way they can get nutrition is because of a feeding tube, I've seen patients that will pull them out because they don't want a feeding tube. A feeding tube does not mean that they won't choke. They can still choke. They can still aspirate and it go into their lungs with the feeding tube. It can be painful. It can get infected. So a feeding tube isn't always the answer. I mean, if the patient wants a feeding tube, that's usually if you come on hospice and you want the feeding tube on hospice, well, you're going to get the feeding tube before hospice and then come on board. Because that's more of an aggressive treatment. Now we take people with feeding tubes and it's okay. Sometimes I have had patients that their family members are like, do we have to keep feeding them through their tube? And no, that's not a normal way to live, to have a tube there. So it is okay to stop that feeding. And that's where it's okay to not force food and not force liquids. But it's amazing how many people have a hard time with letting their loved one be dehydrated or not eat. It's one of those things that probably Americans, okay, you got to eat, got to drink. And it's hard to see your loved one decline like that, but at the same time, they're declining anyway. And the eating or drinking is just a normal part of or not eating and drinking and weight loss and dehydration are a normal part of the declining process. So sometimes that takes a while for the family. Sometimes the family doesn't come around. Their loved one still is going to pass away, depending on what the diagnosis is, but sometimes it's challenging. It's challenging with the food and the fluids sometimes, because it's just hard for us to allow that, I think.
We didn't find it hard for the family, we found it hard for staff.
And hopefully as education becomes, that's one thing hospices and palliative care are also big about education and trying to go into the facilities when possible and teaching their staff. And I will talk to staff when I need to, especially if the family says, I don't want them to be feeding my loved one anymore. They're force feeding and she's irritated by it. Well, then yeah, I'm going to talk to then yeah, the provider or the hospice nurse needs to intervene there, really. Okay, hospice also pays for 5 days of respite in a facility. So the patient's home, either lives alone and isn't able to take care of themselves, starts declining, or there's a spouse taking care of a hospice patient and the spouse needs a break, or the family's going on vacation. Hospice will pay for 5 days respite in a facility, in a long-term care facility. And then sometimes the family and maybe even the patient decide that staying long-term is the best. And we can transition. Hospice won't pay anymore after that 5 days, but there's other ways, sometimes Medicaid or other financial means that can stay longer. But hospice does pay for that 5-day respite, which can be very nice. And it can even be like monthly. So it can be a monthly thing, 5 days respite.
Hospice decided I needed rest. So they sent my husband over to Kingsland, to that Kingsland care, I think.
Kingsland Hills.
And the very first day, he rolled himself down to the back door and figured out how to override the.
Oh, no.
He got the door open, and his buddy who was watching him do this was getting people, and they were all going outside. So they called me and I had to go get him.
Oh, my goodness. There have been cases where somebody's gotten out and they walked down the road a ways, and somebody usually sees them and says, I'm pretty sure that patient or that person's not supposed to be out walking.
Well, he could always figure out mechanical, electrical.
He was smart.
things. So I don't know if he knew his name, but he knew.
But
how to
yeah,
override that.
he had done that so long, but yeah. Thank you for sharing that. Yeah, sometimes we'll offer like hospice will offer dietary counseling. I've already talked about the speech therapy, occupational therapy. That's not all hospices, but some. So there's even short-term crisis care that can be provided. So if a patient's having severe pain or respiratory distress, and it's really challenging to get them comfortable, or their family's having a hard time caring for them, sometimes we will send an LVN or even an RN into the home for hours to sit with them and to keep giving the medications and doing what needs to be done to get somebody comfortable. So there is crisis care in hospice when needed. And sometimes we will put somebody in an inpatient hospice in a hospital if we can't get their symptoms managed at home. Like IV, sometimes we will do IV pain management when somebody's pain is severe and nothing else has worked. And we have even done IV pain medication at home once they go to the hospital and they get a port or an IV access and then go home on the IV Dilaudid. We don't do that very often, but when somebody's pain is so bad and that's the only way to get it under control, we do what we have to. And then there's palliative care forms and hospice forms. Everybody has to have a consent signed these days. And so once the patient and the family agree that they want to either be on palliative care or hospice care, there are consents, and they basically just say really what to expect, and that you have the right to come off palliative care or hospice at any time. If you decide, oh no, that is not for me, or I don't like that nurse, or whatever, you have that right to cancel the services. But there are consents. And I was just gonna for palliative care, the things that you can see decline, and this is hospice too, but weight loss is often something that you would see. Weight loss and not eating much. And sometimes even somebody that does eat a lot can still lose weight, depending on the disease process. There's also skin breakdown that can happen towards the end of life, even with the best of care. There's skin breakdown that can happen. Dehydration, that's a normal part of decline because you just don't have those thirst sensations, or you may not be able to swallow. Sometimes a catheter is necessary, either because of urinary retention, where sometimes the pain medication can cause urinary retention. Sometimes other things can cause the urinary retention where you can't urinate. So sometimes a catheter is necessary, or sometimes a Foley catheter is necessary if there's a bad rash or a bad skin breakdown. Sometimes a catheter is necessary to keep the urine off that area. And then impactions, fecal impactions like constipation, but severe, where nothing's moving through there, can happen too as the body slows down. As everything slows down, you can have bowel obstruction. But we try to take measures to prevent that with suppositories and oral medications if possible, but it can happen. And then the need for more pain medication, more anxiety medication. And a lot of times the patient does become bedfast, where they don't get out of bed at all, even on palliative. That could be palliative or hospice. And then this was just what we talked about earlier about the advanced directives. I cannot stress the importance of having your wishes planned out, and that everybody knows what your wishes are, and for your loved ones also. And really, you're not too young. I mean, even 20, 30-year-olds, you just don't know what might happen. It's good to think about what you would want done. Would you want to be buried? Do you want to be cremated? Where? Do you want to be resuscitated? Do you want CPR? CPR is very traumatic, and somebody that has chronic illness, the outcome of, the chance of coming back from CPR is very slim, even if you didn't have chronic disease, but with chronic disease especially, and then more than likely you're going to be in worse shape. If you get chest compressions, they have to do a compression about this deep, one chest compression, and it can break your ribs, break your sternum. So these are things to consider. If EMS is called and you have a do not resuscitate, which you should have it on your refrigerator or somewhere where everybody knows where it is, then they won't resuscitate you. They will do what it takes to get you to the point, but right before they might have to. Does that make sense? So they would still treat you. They just wouldn't do chest compressions and try to bring you back once you're already gone, once your heart stops. Oh, tell me.
You also need to get what's called an out of hospital.
Yes.
Do not resuscitate, because the one that has to do with the hospital won't work if they find you in your yard or in your home. They'll
That's
start
very true.
CPR anyway.
Yes, that is very, very true. That's why, yes, you get the out of hospital DNR, and you make sure that everybody knows I have a do not resuscitate and I have an out of hospital do not resuscitate. Make sure that if EMS comes to my house, that they don't try to do CPR. And I've had people that said, if you do CPR on me, I'm going to come back and haunt you. It can be very traumatic for the patient, but also everybody around. It can be very, very
By the way,
traumatic.
Since you live across the street from us, we have an out of hospital DNR
Oh,
in our front cabinet when you walk in the door.
okay. Okay, that's good to know.
Don't call
That's good to know. And then, an advanced directive, which includes like the living will, the medical power of attorney, financial power of attorney. Sometimes person will have a medical power of attorney and a different financial power of attorney, and that's okay. There are groups that can help with this type of thing. Like the National Institute on Aging has more information on that type of stuff, and on the paper, the handout at the bottom, this caringinfo.org. I went to these websites and looked at them a little bit, and they have valuable information on if you want to learn more about the living will and how to go about getting one, and or medical power of attorney, financial power of attorney. And this just kind of the decisions, end of life decisions, so that you can be prepared. And then there's also, I didn't print these out. I just thought, and if anybody wants my PowerPoint, I can email it to you or maybe even print it out. I'm not sure, I bet you Sarah could even print it out if you wanted any of the slides. These are community resources that I just thought might be beneficial. The Area Agency on Aging in the capital area, their phone numbers and their email addresses there, and they can help with finding legal assistance for different things. I think it's always important to have poison control number. If you ever, even if you have a neighbor that's a child and you hear that child took 100 melatonin or whatever, got into something, or you feel like you ingested something and you're scared, call the poison control. They are a wealth of information. So I've actually called poison control several times over the years for different things. And they will reassure you when needed, and they'll tell you to go to the hospital when needed also. So, and then this is a sticky subject, but something that I just wanted to put out there. I felt like I should. The suicide hotline for Burnett and Llano County. You might not feel that way, but you may know somebody that does, that feels depressed, suicidal. And unfortunately, as we age and we start losing our friends and our family, and sometimes our other, our independence in other ways, there's a lot of people that do feel suicide might be the answer. So that number, and then Crime Stoppers. There's so much elder abuse, and I was at a patient's house, and he told me, and I don't think this was intentional elder abuse, but he had his well worked on, and he was charged, $5,800 or whatever. Well, in the itemized thing, it said that $750 for labor, but they charged him tax on all of it, including the labor for the person. I don't even know if that's legal. Or if it's, I don't know if you could charge tax for the labor. But I told him, don't pay this. You need to find out if they charged you tax on the labor, because, and they might not even realize it, but they could possibly be trying to get you for every nickel and dime. So just be careful out there. It was the same person. They have Medicare, Part A, Part B, and a supplemental insurance, and he was still getting bills from specialists, or what was the other bill for? Eye doctor. And I said, you call them and talk to them and find out why you're getting a bill, because your supplemental, it should be paid for. So if you think you're getting overpaid or you're paying too much and you're getting bills apart from your Medicare or your supplemental, just check into it to make sure they're explaining it well to you, because they could be, there's just a lot of elder abuse out there. And it's not, it's, if they can get you for an extra nickel and dime, a lot of times places will. And I don't mean, so yeah, this was like healthcare stuff too. And I don't know if it was like an automatic billing thing and it just went out, but it looked like his insurance paid $180 something for the eye visit, but then it was also charging him $180. saying that he hadn't paid. So, and I told him, you just need to call and talk to them. Do not pay it until you talk to them. So that's just something else to be aware of. And then this is a utility, the emergency service. If somebody's electricity goes out and it's really hot or really cold, that emergency line, you can call that. And because it is life threatening in Texas, if your electricity goes out, I mean,
That.
yeah, or when you have a freeze for a week and your heater doesn't work. So that is a number to use. And then the Family Elder Care Guardianship and Money Management Program, they give you a case manager and they can also help with different questions regarding advanced directives. I think there's, and guardianship can be, if you have somebody that can't make their own decisions, sometimes somebody has to get guardianship over that person, and they can help you do that. And with money management too, if somebody needs extra care or nursing home or anything like that, they can help. Any questions? Yes, ma'am.
So we have several people that are online, and I'm not sure what part of the state they're from, but, and they may have asked you the question, but if you feel that you want any of these services and you don't live in the Hill Country area, how would that person go about asking to be assigned to palliative care or to hospice?
Their provider, hopefully, to find out if they have it in their area, I would go to their doctor, their provider first.
Okay.
And then you could search it. You could do, a Google search for that county and what's available in that county.
Okay, thank you.
Yeah, you're welcome.
Kind of along the same lines, will the attendings accept self-referrals to, at least for the evaluation part?
Yes, absolutely. Yeah. Yes, we have some people that hear about us and just want to know a little bit more. And then sometimes we do have to go to their primary for the order, to get them on services. That's like for a hospice. Well, either one.
Do you all provide training for staff people so they have more realistic expectations of the declining characteristics of the, like you said, more dehydration, less appetite, etc. So they aren't trying to keep this person eating like a normal person would.
You're talking about at the facilities?
Yes, at
Yeah.
facilities like different assisted living facilities and places like that.
Yes, and interestingly, assisted livings don't usually have any certified people. Their medication person isn't even certified usually to give medications. It's somebody that goes and applies and is trained on the job to give the medications. So that's the assisted living's guidelines. They just, they tell you we don't have any certified people. Now, there are some assisted livings that will have an LVN that is more like an administrative person, but that's not. An assisted living is definitely more independent than a long-term care facility. But yes, we're actually hopefully going to start doing some education for some of the assisted livings and long-term care facilities if needed, to discuss some of this stuff.
Would a dementia care unit at a hospital be different because it would have more qualified people than an assisted living?
Oh, you mean in a long-term care facility?
Now, this was when my mom was in Glen Rose, they had a dementia unit
Oh, okay.
at the hospital,
At the facility, okay.
at a normal hospital, but it was a different wing.
Okay, well, that would be short-term, probably.
No, she
More-
was in there for 2 or 3 years.
Oh,
It was
okay.
long-term. But it was just a different part of the hospital. But
Okay.
are they more likely to have more certified people than a regular assisted living?
Than an assisted living, yes, probably so. I mean, I wouldn't, there's not too many hospitals that I know have that type of,
Arrangement.
yes. But I would
Maybe it was
think,
just a small town thing.
and I would think it would be more of a skilled facility if it's within the hospital. So they
Skilled
probably,
nursing.
well, yeah, skilled nursing. So they would have to have licensed people there. Yeah, and so the licensing, like the long-term care facilities, they are required to do so much training, and then they have LVNs and RNs, all they have certified nurses aides, the LVN has a license, the RN has a license. They have all kinds of training and stuff. Sometimes they still need more training, or they, there's turnovers all the time in those type of facilities. So the new nurses need that education, or sometimes the old ones need reminders. And we try to educate when we can, when we need to. Do you want to share your story?
I have learned so much today that I wish I had known 10 years ago. But when my husband first entered the hospital, he went to have a PET scan. They found a collapsed lung. Go to the hospital immediately. ICU. Okay, cancer, pulmonary fibrosis. And this lady comes to me and asks, am I interested in palliative care? I was not even nice to her. Total. I had no idea. I had no idea.
Right.
Anyway, long story short, 10 days later, they gave me a choice, hospice, and I said, no, because we were going to move from the hospital and he could not do that. She came back, and she was an angel. She
Good.
was palliative, but she took care of everything, and I just wish I had known more then. And I wish I had certainly known more for my mother's sake. But now I know more
Yes.
for whomever. Watch it, girls.
And we can spread the word. Yeah. Well, hopefully there'll be more and more education, more and more people that do
Oh,
learn
yes.
about it.
So this has been very helpful.
Good. Okay. Thank you.
I would just make a comment that I agree with you that hospice workers are angels.
Oh,
They're just, everyone I've had contact with, they've been so loving and so caring and so compassionate. Thank you.
yeah.
I'm
You're
still in
welcome.
touch with some of our hospice.
Oh, that's wonderful. That's wonderful. Great. Well, I just wanted to end with reading. Well, if I can figure out what I did. Oh, there it is. Is any other questions or comments? No.
Good job.
Very good. Thank you. Appreciate it. So this is a poem that I thought was pretty neat by Ralph Waldo Emerson. This is my wish for you: comfort on difficult days, smiles when sadness intrudes, rainbows to follow the clouds, laughter to kiss your lips, sunsets to warm your heart, hugs when spirits sag, beauty for your eyes to see, friendships to brighten your being, faith so that you can believe, confidence for when you doubt, courage to know yourself, patience to accept the truth, love to complete your life. Ralph Waldo Emerson. Thank you.
What's the name?
I'm not even sure. Let me see if I can find it real quick.
Are we gonna do a sheet?
They said you don't mind now.
Oh,
Thanks for coming.
Thank you. Thanks, everybody, for being with us this afternoon.
Thanks, Sarah.
Yeah, thank you.
Glad that you all came. Hope you can come to some other things.
He was very good, thank you.
You need to sign it. I just signed your name.
Oh, I thought you said.
Well, I didn't know about. Thank you very much.
They had it in one
Thank
central
you.
location. You're welcome. But they telecast it, or they Zoom it or whatever to the other locations. So there were probably more people online.
You saw the names.
Yeah, you get some of the people, yeah. So, and either way, they divided up all the class. You could either do it in person or.
Well, he should have.
I've seen the child watching. Last time, you should take a couple of semester.